Good evening. My name is Dr. David Doman, and welcome to another edition of Housecall. This is Colon Cancer Awareness Month. Find out more right now. My guest this evening is Dr. Raena Olsen, a gastroenterologist right here in Montgomery County. Raena, welcome to Housecall.
Thank you. Thanks for having me.
My pleasure. Tell our viewers briefly about your professional background.
I studied in Kansas City, Missouri, did my residency and fellowship in New Jersey at UMDNJ, and for the past 14 years have been practicing gastroenterology in California at Cedars-Sinai, and recently moved here and joined MedStar.
Very nice. So let's go on to discuss the topic at hand, colon cancer. Exactly how common is this problem in the USA?
You know, Dave, people don't realize quite how common colon cancer is. Other type of cancers seem to get a lot more recognition or press, but colon cancer is the third most common cancer in both men and women. It's the second leading cause of cancer death in both men and women, lung being number one. If you kind of think about it like this, lung cancer is number one, breast cancer, which everybody is aware of, is number two in women, and prostate is number two in men. And colon cancer is the third most in both men and women. So it's extremely common. It's probably expected that about 250,000 cases of colon cancer will be diagnosed in this year alone.
Very interesting and very important. And I'm so glad you emphasized to our viewers several times that it is a problem in both men and women. As you know, for a long time, it was a misconception among women that colon cancer was a male problem.
Yeah, that is true. And it's certainly not. Men and women get it at about equal rates. There's about a 1 in 23 chance that men will get it and 1 in 25 that women will get it.
Yeah. Interestingly, though, there are some differences between different ethnic groups. Share with our viewers what some of that data shows.
There is ethnic and racial differences in colon cancer. African Americans are the highest race to get colon cancer in America. And we think part of this is because there is less access to getting a colonoscopy and checking for colon cancer. And worldwide, Ashkenazi Jewish patients have the highest rate of colon cancer. It used to be in America, you know, a few years ago, we would tell patients, if you're African American and you're 45, go ahead and get your colonoscopy now. But we've now changed that to every patient should start at 45, not just African Americans. It'll be interesting to see as time goes on if that African American recommendation will go even lower in age. Time will tell.
Absolutely. You mentioned the change in recommendations to begin screening average risk individuals not at age 50, which was the standard for many years, but has now been advanced by the GI societies and the American Cancer Society to 45. Why was that change implemented?
The incidence of colon cancer has been going down in patients over the age of 50, which is a fantastic outlook. However, the incidence of colon cancer in patients less than 50 has been going up about 2% per year. And part of this is because we simply were not checking them because we weren't suspecting colon cancer in this younger age group. Now that we know that younger age group population are showing up more with colon cancer, we are checking them sooner. The sooner we detect polyps and cancers, the better the outcome.
So for our viewers that are 48 years old and have been saying, I'll wait until I'm 50 to get the procedure, is it fair to say that they're actually 3 years late?
That's totally fair and accurate at this point. When you're 45, that's when you pick up the phone and you make an appointment.
So what are some of the risk factors for colon cancer?
First, it's age. Definitely, the older you are, the higher your chances of getting colon cancer. And, that's not one that we can escape. Uh, Genetics is another one. If you have a first degree relative, meaning a parent, a sibling, a child with colon cancer, your chance of colon cancer goes up 2 to 3 times. You can't really escape that either. But there are other risk factors that you can have control of. For example, smoking. If you avoid smoking, you can decrease your risk. Other things that may increase your risk is alcohol. If you are a drinker of 2 to 4 or more drinks a day, that increases your risk. If you have a sedentary lifestyle, that increases your risk. If you are obese, if you eat foods that are high in processed chemicals and red meat on a regular basis, those are potentially things that can increase your risk. If you have some underlying diseases such as Crohn's or colitis or radiation to the abdominal region, that increases your chance too. So those are some of the risk factors.
What about diet? I'm sure our viewers are wondering whether a high fiber diet or some other diet might lower their risk. What's the latest views on that?
100% eating foods from the earth, which is mostly plants, are going to be your best friend. Patients who eat a high fiber diet, meaning 25 to 35 grams a day of fiber, are the ones who are best off. People who eat a animal rich diet are at slightly higher risk, especially if that meat is processed meat.
What are the symptoms of colon cancer?
This is the problem. Colon cancer typically doesn't have any symptoms, which makes it a little tricky because often patients are more willing to come in to get a colonoscopy or screen for colon cancer if they're having symptoms. But typically, once symptoms are present, it's a little bit more advanced. So I would say the number one thing is there are no symptoms. And then if you do have symptoms, the ones to look out for are change in bowel habits where your stools are different from baseline, meaning if you've never had constipation or you've never had diarrhea and now you're having it constantly, rectal bleeding, change in your bowel habits where your stools are pencil thin. Those are things to look for. Your doctor may also notice anemia. You may notice fatigue or weight loss, which is not intentional.
Our viewers will tell you that they hear a lot about not only colon cancer, but also colon polyps. I share with the viewers what exactly is a colon polyp and why is that an integral part of our discussion this evening about colon cancer.
Colon polyps are the beginnings of a colon cancer. It is a cluster of cells, and they look like little pellets or mushrooms if you're a visual person, and they start as little tiny things in the colon, and over time, meaning 5 or 10 years, they grow up and get larger and turn into cancer cells. So if we are able to find the polyps and easily take them out, which that's what we do during a colonoscopy, they can't grow up to become a colon cancer. So in that sense, colon cancer is preventable. Our mantra is colon cancer is preventable, it's treatable and beatable. And you have to be, on top of your health to make sure that you're getting screened. That's why doing things like this is so important, especially during colon cancer screening month, the month of March, because it brings recognition to a disease that doesn't get quite as much press as it deserves for as common as it is.
Well, you made an excellent case for the need to perform colon cancer screening. So let's go on then to discuss some of the screening options. At the top of the list, of course, is colonoscopy. Share with our viewers from beginning to end what exactly is involved with scheduling and ultimately experiencing a colonoscopy?
Colonoscopy is definitely the gold standard in colon cancer screening. Sure, when we go in to do a colonoscopy, we're looking for colon cancer, but in reality, most of us go into a colonoscopy hoping to find polyps, remove them, so then we never have to have the discussion with a patient of, hey, you have colon cancer. Because if we are able to remove the polyps early, it prevents patients from getting cancer. Basically, to have a colonoscopy, you have to have a cleanse the day before, which consists of a liquid diet and a oral cleansing solution. That's the worst part of the colonoscopy. And if you ever talk to anybody who's had a colonoscopy, this is the part that everybody so-called dreads. But it's one day of washing out the colon. That's the hard part. The day of the procedure, you come into the surgical center, you get an IV in your arm, which is one little stick, not so bad. And then you get brought into the colonoscopy suite. You're covered the entire time, so you have modesty throughout the entire procedure, as I know some patients are a little nervous about that. And, you know, during the colonoscopy, patients often say, oh my gosh, I hope I don't leak anything out or make any embarrassing sounds or smells. That is something completely not even to worry about because the instrument that we have takes care of those kind of things. So it's a non-issue. Once a patient is put to sleep, which is a very gentle way of being put to sleep by the anesthesiologist, we gently go in with the colonoscope, which is about the size of my finger, and we insert the camera to the end of the colon. The colon is about 5 feet long, which is the reason why you have to cleanse it the night before. And the cleanse is so harsh. There's so much colon to see. And, we look at all of the walls of the colon looking for polyps and cancers. And if we see any, we go ahead and take it out right then and there. And it is a completely painless procedure. And once we're done, the patient gently just wakes up on their own. And I would say probably the most common thing people say to me after a colonoscopy is, when are we going to start? That's probably the most common thing people say.
What can patients expect as soon as the procedure is done?
When they're done, they're going to be in the recovery area and they'll slowly wake up. I think most of them are surprised that the procedure is already done, and they get a little juice, they get a little crackers, they may have a little bit of gas that they need to pass. That's about it. And then they go home, they have breakfast with whoever drives them because you can't drive yourself after a colonoscopy since you were put to sleep. And then you maybe take a nap in the afternoon, wake up and go on with your day just like any other. Legally, you're not supposed to drive or do anything important. So it's a day off.
We have 1 minute before we go to break. Briefly, is this a procedure covered by insurance?
Yes, it is. The Affordable Care Act requires that preventative testing be offered to all patients. The modality may differ from insurance to insurance, but pretty much every insurance will cover all forms of screening for colon cancer.
We're going to pause briefly for a public service announcement. More with my guest, Dr. Raena Olsen. The topic recovering is colon cancer screening. We'll be right back.
After 15 years of smoking, Eva Marie quit. There's a new lung cancer screening that could save her life. You stopped smoking. Now start screening. Learn more at savedbythescan.org.
We're back. My guest this evening is Dr. Raena Olsen, a local gastroenterologist, and we are discussing colon cancer screening options. Raena, when we paused for the break, we were discussing colonoscopy, and you pointed out it was covered by insurance. This, of course, being a procedure, like any procedure we doctors do, has a rare risk of complications. Our viewers, of course, would like to hear more about that. What are some of the rare complications that can occur with colonoscopy?
All medical procedures have a potential for complication. Colonoscopy is incredibly safe. when done in the hands of somebody who's done many, many of these and is experienced. With that being said, the complications that we educate patients are bleeding and perforation. Perforation is where there's a tear in the lining of the bowel, and intestinal fluid can leak out of the bowel into the abdominal cavity, which then causes infection. So if this were to happen, it does require hospitalization and antibiotics and possibly even surgery. It happens in about 4 in 10,000 cases. And bleeding is the second complication to know about. That happens in about 8 in 10,000 cases. And sometimes when a polyp is removed, there's a blood vessel that's in there that's hidden that we just don't see. And it starts bleeding after the polyp is removed. Most of the time we can take care of it right then on the spot. We have a little clip or some heat to cauterize and we're able to stop it. Rarely patients have to go to the hospital and get a blood transfusion or have another procedure, colonoscopy procedure, so we can stop it at that time. But those are the two that people should be aware of.
You mentioned clipping, and that's something, of course, we can also do if there is a small tear. We can often repair it right then and there, and the patient need not go to the hospital.
Yes, definitely. Thanks for pointing that out. Yes.
So there are, of course, other options available to patients for colon cancer screening. So let's go through these together to amplify the dialogue with our viewers this evening. What are your thoughts about virtual colonoscopy?
Virtual colonoscopy is good. It's a good test. What you can expect, it's a radiographic test. So patients take a cleanse, which is the hard part of the test, where they have to clean out their entire bowel the night before. They come into the radiology department. They have air put inside the rectum. That part is a little bit painful. There's no sedation with this one, so you're going to feel that. And it's about a 10-minute test where they do a CT scan to look for polyps. It picks up polyps about 9 millimeters or larger. And if something abnormal is found, then simply do a colonoscopy at a later date to take care of that lesion that's found. This is a newer test, and it is not commonly covered by insurance, which is the biggest problem with it. So although I do like it, I don't like the price tag that comes with it, so I often do not recommend it to patients who don't want to pay out of pocket.
And as you said, they are prepped for the Xray, and if it's abnormal, then they have to prep a different time for the eventual colonoscopy.
That's the hard part.
I would imagine many of our viewers would find that to be a big disadvantage. What about the test that's advertised on television, Cologuard?
Cologuard is a pretty good test in that you can do it in the privacy of your home. It's an easy test to do. You can kind of think about it as poop in a cup, where you put a stool sample inside a collection cup and submit it to Exact Sciences, and they look for DNA mutations in the stool, and they also check the stool for hidden blood. And a combination of those two tests, if they're normal, gives you a clearance for 3 years that you probably don't have colon cancer. So it's good if you are refusing a colonoscopy, because something is better than nothing when it comes to screening, but it is certainly not as sensitive as a colonoscopy in detecting polyps and cancers. That's the downfall.
Many of our viewers, especially older ones, are acquainted with an older test called flexible sigmoidoscopy. What is that role in 2022?
Flexible sigmoidoscopies are similar to colonoscopy, except they look at about 1/3 of the colon. They look at the lower large intestine. So that one you do take a cleanse. You come in and sometimes you're sedated, sometimes you're not. And we take a camera and gently insert it into the rectum and take a look at the left side of the colon. If there's polyps present, we're able to take them out. However, if there are polyps present, then patients have to come back and do a colonoscopy. So I think that if you're going to go through the effort of doing a cleanse, doing a sigmoidoscopy seems kind of silly, because why not just look at the whole colon? We know that colon polyps occur on the right and on the left. Historically, it's been thought that in America, there's more colon cancers on the left than on the right. That's why sigmoidoscopy was even an option. But remember, the whole purpose of this is not to look just for colon cancers, but to look for colon polyps. So if you're limiting your exam to only the left side of the colon, you are missing quite a few polyps that could have been removed at early stages. So I don't recommend it, although it is a recommended test for colon cancer screening, and it's done once every 5 years.
And certainly, historically, one of the reasons flexible sigmoidoscopy fell into disfavor was years ago when Ronald Reagan was president. He would get a regular checkup at Walter Reed Army Medical Center. And every few years, they would do a sigmoidoscopy on him, and they would find small polyps and remove them. And finally, a number of gastroenterologists called the White House physician and said, you may be missing polyps in the right side of the colon. So ultimately, he underwent anesthesia. Power was transferred temporarily to Vice President George H. Bush. And when they did the colonoscopy, they found a cancer in the cecum, which is the far right of the colon. From that point forward, flexible sigmoidoscopy fell into disfavor nationally and internationally. Fortunately, they picked up the cancer early enough and they resected it. It saved his life.
That's great. So, that's a great story.
Thank you. Thank you. Anyway, what about even simpler tests like fecal immunochemical testing?
That's the old-fashioned stool on a card where you wipe a little bit of a stool specimen onto the card and send it in. And using chemical, we test to see if there's any hidden blood in the stool. If it's positive, then patients go straight to a colonoscopy. And if it's normal, then they don't need to repeat the test again for another year. You know, Dave, I think if something is that simple of a test, it's too good to be true. I mean, it is a very simple test, but there are a lot of polyps that it misses, because a polyp needs to get big enough to have a large blood supply and get, fragile. That way, when stool passes the polyp that's large and very vascular, it'll bleed, not blood that you can see, but hidden blood. And that blood gets picked up on these tests. So yes, it'll pick up polyps that are large and cancers that are early, but it misses the smaller polyps. And it would be a shame to miss something small where when you remove it when it's small, it's easily treatable. So I don't recommend it, although it is a recommended test for screening, because something is better than nothing when it comes to screening.
Absolutely. Our viewers are wondering, well, okay, you've made an excellent case that I should get a colonoscopy. So let's take different scenarios. A colonoscopy is performed in somebody and you find a large polyp and remove it. What do you recommend as their next follow-up procedure?
The follow-up colonoscopy will depend on the size of the polyp as well as the pathology or the histology. So different kind of polyps are a little bit more dangerous or risky than others. So based on that, patients will come back in either 1 year or 3 years or 5 years. And if their colon has no polyps, they come back in 10 years.
And then if a cancer is found, the big fear of patients is they automatically will need a colostomy bag. Share with our viewers what are the circumstances where a colostomy bag is necessary with surgery and when it is not.
Most patients, when they have colon cancer, if we find it early in stage 1 or stage 2, they don't need a colostomy bag. They just get the tumor removed, and the healthy part of the colon is reconnected together. And then after they heal from the surgery, they'll have chemotherapy. If patients have more advanced cancers that's causing blockage of the bowel, and the cancer is quite advanced, they may need a temporary colostomy, but that's often reversible once the tumor is removed and patients have been treated. The ostomy can be removed and they can be connected back together.
You mentioned other treatment modalities. So share with our viewers some of the treatment modalities available after surgery is completed, and what sort of patients qualify for that.
Patients can have chemotherapy and radiation as part of the treatment. And it is a difficult year when they are undergoing surgery and chemo and radiation, but often the outcome afterwards is incredibly favorable. Patients often, when they get the diagnosis of colon cancer, think the worst, but colon cancer actually has a very good outcome once treatment is over. That 1 year of treatment is rough. There's no denying that, but there's definitely hope at the end of it, and patients often do pretty well.
If our viewers have any questions about colon cancer, how can they reach you?
They can certainly email me or call my office. I'm always accessible and happy to answer anybody's questions. You know, one thing I wanted to also mention, Dave, because I think this is something that patients may have questions on, is we talked about start time for colonoscopy changing to age 45. But now the recommendation is to stop screening at the age of 75. And then when patients are from 75 to 85, we individualize it. Meaning if a patient is quite healthy, which many of our patients are, we go ahead and do that colonoscopy because we know that they are very, healthy, great 75 to 85-year-olds. If somebody is 75 to 85, but they are quite old, 75 to 85, with many medical problems, we defer the colonoscopy because we think that the benefit does not outweigh the risk of it. And once they hit the age of 85, at that time, it's now recommended that we stop the screening.
Thank you for an excellent interview, Raena. My thanks to my team at the studio, and my thanks to you, the viewer, for allowing us into your home this evening. Tell us how we're doing. You can reach me at my MedStar email address posted on the screen. As for our next topic, it's going to be an important one. A member of the Georgetown Endocrinology Division will be providing an update on the latest treatment and therapy options for diabetes mellitus. It's going to be a fascinating show. See you then next time for another edition of Housecall. Good evening.